Hey Renu, how are you?
I'm good, Declan. How are you?
Good, nice to be back in the GUcast studio again.
Always nice to
I
be
was
back
overseas
here.
a couple of weeks ago. We to rough it at ESMO.
Yeah, you brought all the equipment back, right?
I did. Yeah.
Put it all back in the right spots.
Yeah. Well, when we're on the road, we kind of wing it a little bit, but yeah, it's nice to be back in the.
But you got some great
studio.
interviews, and that
was
ESMO
really good.
episode was really good.
We just did prostate cancer because there was so much prostate cancer, but boy, bladder cancer was huge as well. So we'll come back and talk about it. We'll have to talk about EV302 when the paper actually gets published. But pretzels are all the rage, and it was.
We're going to start
really,
some
really
local trials. I mean, it is all the rage, and I think it's going to be a really exciting field in the future.
Yeah, it really was. But that episode we posted last week, which was our ESMO highlights, and we focused on mostly prostate cancer data with radioligand therapy. We chatted to some great authors, and we also talked about the EMBARK trial, enzalutamide in the BCR setting, and also about the multiple failed IO trial in prostate cancer.
You love tweeting about this.
Yes, but
yet another failed trial.
Yes, so it's prostate cancer again today.
It is, but it's a very important topic, I think, because I think this has been one of the game-changing aspects of prostate cancer in recent years.
It has, because what we're going to talk about today is metastatic hormone-sensitive prostate cancer. This is a Bayer-themed episode. So as you know, we have a partner program at GUcast, which has enabled us to have this nice studio and push out a lot more content than we were able to do before. And that's all thanks to some great partners who you can read about on our website. And then every so often, one of our partners will get together with us and say, hey, this is a topic of mutual interest.
Yeah.
And that's what we mean when we say a themed podcast. And our friends at Bayer Pharmaceuticals, who are silver partners of GUcast, are supporting us on this podcast because metastatic hormone-sensitive prostate cancer, AR pathway inhibitors, which is today's topic of conversation, is of interest to certainly our audience and also to Bayer, who have Darolutamide in the market.
Absolutely.
And actually, the reason it's quite good timing because we're in December here in Australia, December 2023, and as of the 1st of December, we've just had Darolutamide, AR pathway inhibitor, reimbursed in Australia for men with metastatic hormone-sensitive prostate cancer.
It's very exciting, yeah.
It's great.
It's
so
great news.
Exactly. So now
Early
we've
Christmas present.
Exactly. So this has been a big year for AR pathway inhibitors in the metastatic hormone-sensitive setting for our patients here in Australia, because now Darolutamide is available, reimbursed, joining apalutamide, which was reimbursed a few months ago, and I think enzalutamide is on the way.
On the way,
can't remember. I'll have to
hopefully.
double check.
Yeah.
Maybe our guest might know a bit more about it.
Yes, we should. Yeah, absolutely, we should. We've chosen him for a reason.
Yeah. Joseph Ischia, Associate Professor Joseph Ischia, is a urologist here in Melbourne. Joseph, thanks very much for coming to the GUcast studio.
It's an absolute pleasure, Declan and Renu. Lovely to see you guys and see your very fancy setup. This is very exciting, and I'm very impressed that your son allows you to use such fancy equipment without his assistance.
Well,
that comes at a price.
Yes,
right?
it's kind of a shared space. Myself and my 11-year-old have. So he's still got an Xbox over there in the corner.
Beanbag, can't
with
be
like
touched.
big monitors now as well. So Joseph is a urologist here in Melbourne at Austin Health and associate professor at the University of Melbourne. And we can't go much further before we talk about this without mentioning your pedigree as a podcaster. Now, I know you said, I don't have much time to do it at the moment, but Talking Urology was one of the original big podcasts in urology, Renu, wasn't it?
The podcast has started it all, an inspiration to all of us. Joseph.
It was. We got in very early, so sometimes it's better to be, early than good. And I thought that was the policy we used. But in fact, no, we had a lot of fun with it. I made the mistake at an advisory board of saying, I wish there was. I've started listening to these things called podcasts. I wish there was one that I could listen to in the car on the way to work and just sort of cover off like a paper. And at the ad board, they thought, that sounds like an okay idea. And then 2 weeks later, they rang me and said, we'd like you to do it. And as you guys would know, they are a lot of work, and it was a lot of fun. And now we'll let the big boys do it. So you guys are doing a great job.
So he says. But I was just saying to him before we came on air, Renu, that when you Google best urology podcast, which I only do every few weeks or so.
In the hope that GUcast is up there, right?
That's right. Have we shifted? But Talking Urology is still always right up there because you were there at the start, but also you published a lot of great content. It was very popular, and we still listen to back episodes. You were on Talking Urology.
Yes, and I've been on site with Joseph. I mean, I remember when we interviewed Axel Vesberger,
Yes.
right? At a conference.
Yeah, absolutely. That was the way to do it.
Yeah, it was, you know,
when they were
before podcasting became cool, Joseph did it.
Yeah.
Before the guests realised how many people asked them to do podcasts.
Yeah, that's right. Now you're getting tormented.
Yeah.
But look, it's still out there. Talking Urology, we'll put a link in the show notes. There's some great content there. Actually, what I like about it was you still, of course, have a passion for education, and indeed you often make some really good points on social media about frustrations with digesting multiple papers and the amount of papers out there, etc., etc. And you have some good ideas about slimlining that. But that was one of the goals of Talking Urology, was to get these key papers, talk to the authors. So the content is still very relevant because, of course, landmark papers are landmark papers, and there's a great library, great back catalogue on Talking Urology.
And sometimes it feels like you need a degree to be able to read these papers and understand them. So, you know, anything you can do to simplify it.
Well, this is one of my great passions, Rena. You're absolutely right. And in fact, I've got this wonderful graph that looks at, there's a concept of readability of papers. And in the last 10 years, you need to have a PhD level of education to be able to read the average paper. And in fact, they make the point that most journal articles were written to be written, essentially not to be read, written to be published and not to be read. It is tough. And I think it's one of the great challenges of our times, is how do we start to convey information in a more easily accessible fashion? And podcasting is a fantastic way to do it. You know.
Right.
You've got the right people.
And look, at the end of the podcast, we want to also ask you about one of your other interests, because one of the reasons you're not doing as many podcasts at the moment is you have other interests. You're into the medical device development industry, and you have a really interesting idea. And maybe we'll talk about it a little bit at the end.
I hope we can. This is the problem. You don't want to have really good ideas late at night because they end up consuming your life. Essentially, we're doing it, mate. It's fantastic. Well, I look forward to chatting.
Yeah, well, look, urologists, stay tuned into it, because we all like fiddly things. That's what urology is. Doing a lot of endourology, especially. That's the not quite spoiler alert. Is if you've been up late at night, very frustrated, waiting to stick a stent into somebody, hang around and listen.
Stay tuned to the end of the podcast.
Exactly right. But look, onto the main chunk of it. So, Renew, I suppose we've talked a bit about combination approaches in metastatic hormone-sensitive prostate cancer over the past year or two, but it just really feels end of 2023 in many regions around the world that the AR pathway inhibitors are now, well, they're kind of registered in most countries. They're indicated, but they're becoming more and more available. The reimbursement is there, but we know there's a lag, because real world data still tells us that despite stuff being available, there's a problem with utilization. A lot of men are getting started on ADT for metastatic prostate cancer, and we can talk about imaging and synchronous and so on, metachronous. But they're missing an opportunity to have the benefit of a combined approach, and I think it's very clear, we'll talk about that a combined approach is really, really valuable for patients, for survival, quality of life, etc. So it just feels that at the time we're in, now is the time we need to be getting the message out so people understand these options.
Yeah, I think it's a new era, and there's a new standard of care, and I think that's what Joseph is going to tell us a bit more about, because he has a passion for this.
Yeah, exactly. And look, Joseph, I suppose Charted was 7 or 8 years ago now, and it clearly showed combinations work, because docetaxel did, but patients don't really want docetaxel in this setting, do they? I don't hear anyone talking about docetaxel at the end of 2023. The APCCC is clearly saying if you have an AR pathway inhibitor available, that should be the doublet, that should be the combination approach. And the role of chemo on top of that is kind of to be discussed. But it seems to me that there's been a big change from ADT and chemo, from Charted, Stampede era, to look, if you have access to one of these AR pathway inhibitors, darolutamide, apalutamide, enzalutamide, ARPI, I suppose we'll throw in there, that should be the doublet of choice. Then we can discuss triplets. But what are your thoughts on that suggestion?
Absolutely. I agree that the doublet, triplet content has changed. Absolutely. And Charted brought our medical oncology colleagues all the way forward. Up until then, it had been the domain of urologists, this early metastatic disease. And with Chris Sweeney and his amazing trial, and Nick James and the Stampede, we really did bring them all the way forward. And it's wonderful to have them with us so early in the journey. But it's almost like now we have these new tablets available, the novel hormone agents. And I challenge you on that, because you keep calling them AR pathway inhibitors. Who decides what's the best acronym? We could maybe a topic for
That
another
is true.
podcast, because they all get thrown around until we finally all coalesce onto one. But
or one that's easy to pronounce.
exactly.
ARPIs, I mean,
ARPI,
RCs,
ARPIs,
AR signaling inhibitors.
So I don't know who
RCs.
decides that.
second
Maybe
line
it is Chris Sweeney.
anti-androgens.
Chris Sweeney one day
Maybe,
at
yeah.
11:30 at night at a conference says, everyone, we're going to call them novel hormone agents. Oh, right, good.
That's true.
Maybe this is a Twitter poll that's going to roll out after this episode. ARPIs, RCs, NHAs, etc., or something else. All right, there you go. Stay tuned. We'll post it out.
So it's brought it forward. Now we're having these discussions with them about what's the best treatment option. I think we will, as urologists, we are very comfortable in this space, right? But up until I think charted, we would start men on ADT. We would add in bicalutamide either at the start, and we sort of moved away from that for a while because maximal androgen blockade probably didn't matter. We'd bring bicalutamide in, which was a first generation anti-androgen. And so I think this is a great opportunity for us. And, and there was no clinical evidence that it was beneficial, really. And now we have these extraordinary drugs, all three of them, that have an overall survival benefit, if not given with ADT. That's one of the controversial things, which would be fascinating to talk about later. And it's something that's right in our wheelhouse. And I think this is the key thing now is how do we decide who are the right people to have chemotherapy? I think there's still a role. I think young men, terrible disease, visceral disease, where the biology is going to be important, you will see people getting triple therapy. But the vast majority probably will get doublet therapy up front if it's available. I think one of the important things might be in different countries will be the cost, because docetaxel is actually relatively cheap compared to what these drugs will be. And another one of my passions is who should be worried about the costs? Is it the urologist or the medical oncologist, or is it in Australia the PBAC? And I'd argue strongly that it is not the urologist. There are people at the PBAC who are far cleverer than I am, who have decided that for the indications listed, it is a cost-effective treatment when you take into account survival and quality of life. So I think nearly everybody with metastatic hormone-sensitive prostate cancer, and nearly everyone, just leaves out a few, like the slow movers and the elderly and stuff like that are really old, and probably something will catch up with them. Nearly everybody else should be on these agents.
And I think that's right, Joseph, because we can argue a lot about duplet versus triplet therapy, but I think the real mistake is having them on sole agent ADT. Right, that's the culture that we have to move away from, because OS benefit is like the holy grail of clinical trials, and we've got these great trials that all show an OS
30-40% benefit.
So that is significant. So duplet, triplet. Okay, well, maybe you'll get it wrong, maybe you'll get it right, maybe you'll choose a patient correctly, maybe you won't. But the real mistake, and what we still see at our MDTs, are these patients with metastatic hormone-sensitive prostate cancer that are on single-agent ADT.
So for people out there listening to this podcast, urologists, radiation oncologists especially, I think that group of people who tend to have patients with localized disease that might relapse, or as urologists, we tend to diagnose the metastatic disease. Think very carefully when you're starting a patient on ADT alone. As you listen to this podcast, if someone comes into your clinic tomorrow, into your outpatient clinic, and you're starting ADT, you have to think, why am I only starting ADT?
Yeah.
Shouldn't we constantly challenge it? Maybe there's a small group of people, we talk about ADT monotherapy, but for the vast majority of people who you think, based on this scan or this clinical circumstance, I'm starting this patient on ADT, you need to strongly think, why am I not also starting that patient on an AR pathway inhibitor? Certainly in Australia now with these drugs now reimbursed.
Exactly.
So I think there's a couple of things that people might have ticking through their minds. One is, can we do intermittent ADT? Because there's certainly still a role for that, I think. I think they want to have low volume disease. I think the great Maha Hussein study showed that there's really not much of a role for intermittent, I think, if you've got high volume disease. So can intermittent work? And then the second thing about these agents is whether or not they are something that you are comfortable doing.
Yep.
And so that's it. So as a urologist, if you are not comfortable doing it, you need to refer on, because, and this is one thing that I think is really important, at every step of the disease from non-metastatic CRPC on, if you delay the introduction of the novel hormone agent, there is clear evidence they do not do as well. And that's the progression-free survival 2 point in the Spartan study with apalutamide. If you delay the introduction of apalutamide by even just 4 months, those curves never catch up. And so is there the same emergency at metastatic hormone-sensitive prostate cancer? probably not to the same degree. But at every step, these agents are effective, and the earlier we give them, the better. That is proven to be the case. And I can't think of a reason in the biology that would change just because it's hormone-sensitive prostate cancer, now that we have the results of these studies.
And that's part of the argument, you know, when we're looking for NMCRPC, you know, a lot of people argue, well, is it conventional imaging? Is it, you know, novel imaging? But the thing is, no matter what stage you catch it at, it's beneficial.
Absolutely. So why would it suddenly not be because you've got
Exactly.
PSMA positive METs rather than conventional imaging?
Yeah.
So they're 7 millimeters bigger if they're...
And the truth is this whole class of NMCRPC is a man-made definition. And it's really just out there so that we can start patients on these drugs earlier.
And we posted an MCRPC episode just a few days ago as well, when we talked about exactly those topics. But let's go on to the imaging for a second, Joseph, because as Renu just said, we can sort of, we tie ourselves in knots sometimes. Is it based on PSMA alone? Is it high volume, low volume? But in Australia, when the reimbursement started to come in earlier this year, it was very interesting because we didn't know whether the reimbursement authorities in Australia would mandate, for example, high volume, low volume, must be conventional imaging, you know, things that we saw in the pivotal trials, but they didn't. They made it very simple. It's basically, if you've got a patient with metastatic prostate cancer, if it's metachronous or synchronous, if it's PET imaging only, conventional, if it's high volume, it doesn't matter. So it's very simple. So that's why I try and, you know, remind myself of that message. If there's a patient out there, even if we're thinking, oh, maybe he can be intermittent over the years, and we're starting ADT, why would we not add in an AR pathway inhibitor? I think that's the main thing for me. And yeah, and having Darolutamide come into the market just this week is obviously another choice we have now, because I suppose that's the other thing we wanted to pick his brains on, Renew, is about, well, how do you choose now? We got, well, you know, a few of these drugs in.
And that's the thing. I think, you know, traditionally we've had, you know, this whole combination of abiraterone and prednisolone, and that almost seems a bit too difficult, right? It just
we're not
seems
that
hard.
clever.
We're not
We're
that
not
clever.
steroid.
Yeah,
we're not
like
steroid clever.
And we're really not. But we don't have that problem anymore because we've got 3 drugs that, you know, that work well. We know the data. I guess we're kind of spoiled for choice. Yeah.
You know, the steroid problem for us as urologists is probably the drug-drug interactions. That is one thing we do need to be a little careful of if we are going to prescribe them. And they're important because you will see genuine effects with, and they're different medications that are affected by it. And so there's a fantastic sheet that actually we're putting together with USAN, so the Urological Society of Australia and New Zealand, which will be a sheet with the drug-drug interactions outlined. So in fact, if you do commence one of these drugs, you can do a quick run through, are they on any of these drugs? One of the beauties of darolutamide is that the list of drug-drug interactions is very, very small. Or you can just send along to their GP and say, I've just commenced them on this, watch out. So for example, they notice that some people that start these medications all of a sudden notice they're getting reflux. And, you know, it's giving me reflux. In fact, what's happening is that their pantoprazole is no longer as effective because it's been affected by it's been cleared more easily because they've stimulated those enzymes in the liver. So it's not that it's not effective, you've actually just changed the drug. You might have to increase the dose or change it over. So that's probably the one thing that we really do need to be aware of, and our medical oncology colleagues will very much enjoy pointing out to us if we don't take it into consideration, because it is important, because you know, you're more likely to clot if, you know, the dabigatran and stuff is less effective. You have to probably increase the dose and keep an eye on their bleeding times and stuff. But that's all stuff that can be managed, I think, by a GP with the right warning. Just be aware, this is going to change. Do you mind helping me guide them through this process? Because I've got a drug here that's going to extend their life with prostate cancer.
And are you comfortable starting these drugs? You've been at this for quite a while, in the non-metastatic setting, because we had reimbursement in Australia in that setting before we now have it in this setting. So you're comfortable using drugs? I'm
comfortable because, one, I'm happy to have a quick look through the drug-drug interactions. You've got to remember, a lot of these drugs, you know, it's all drugs that probably they stopped producing in 1970. Like, you know, ketoconazole, as effective as it was for prostate cancer, it's not something we use anymore. But all the other drugs, you just got to check and make sure they're not on it. So that's fine. And I think the thing that gives you comfort is you just need to be able to do 2 things. Are you happy to make a phone call and sit on the line and talk to someone at the PBS or at the PBS? If you're happy to do that, and the second thing you've got to be happy to do is, if they do experience side effects, are you happy to dose reduce? And this is one of the easiest things in the world to do, because we go, oh, they got side effects, they're fatigued, or they've got the rash with APA, or, you know, maybe more fatigue with Enza perhaps. Are you happy to dose reduce? And it's so easy to manage. It really is. Just make a phone call. You know, your medical oncology colleagues are great to chat to. They're often in the clinic with you if you're in a public setting. But I'm happy to reduce the dose by half. You know, we can talk about side effects in a minute. I don't know. Do you want to go into it now?
But I'm wondering, Joseph, you know, those are the typical kind of side effects that you will see on a pamphlet for darolutamide or enzalutamide or apalutamide. But what about those odd things? You know, what about if they complain of abdominal pain or if they complain of, vision loss or memory loss? You know, unusual things that you maybe wouldn't expect. How much more work is it for you then to work up those patients and make sure there's nothing serious going on? Do you have to discontinue the medication completely? I think those kind of things would...
They're good points you make. Have you ever looked at the USAN's urology website? You know, it says that it's got something, we are surgical, like we're experts in the surgical and medical management of people with urological problems. We are medical management experts, right? We do take it on. We treat lots of things medically. When you look at the management of LUTs, the management of overactive bladders, you know, the management of these conditions like stone disease, we can start allopurinol and we can manage, you know, dissolve uric acid stones. Why all of a sudden are we afraid to manage these people medically? So I think I've not had an abdominal pain problem, but it might be something I started it and then 3 days later I got it. Actually, you know, listen to your patients, make sure they haven't got something else going on. Obviously, because we are doctors, we can do that. But then you can just halve the dose. Like that's what you do. They come in, and I always get them back at about 4 weeks because a lot of these side effects will come through in that time. So one of the main things, and we'll often miss it, and you need to ask the partner, ask the wife, how's his cognition? And they'll go, he's pretty forgetful or he's not as sharp. Reduce the dose. Seriously, I go to half dose, I get them back 4 weeks later. He's still not very good. I put it down to 1 tablet when we're dealing with the 4 tablets, so the Enza and APA. I don't see as much fatigue with darolutamide. They get a lot of that from the ADT. I don't think it adds much, but it's certainly something that I would do. And then you're on 1 tablet, they're not happy. I put them down to 0 tablets. And if they're still not happy, you go, well, it wasn't the tablets. You see, so then I can go back up. I actually work back up. So I see them a lot in that first 6 months because you are finding your baseline. You're trying to find what they're doing. So one thing that can happen is, do you start ADT? And you've got a 6-month window in the PBS listing before you need to start the novel hormone agent. Just saying it out there, as NHA, for the acronym battle that is on now. You've got 6 months, but I don't want to leave it too long before. So I tend to start them at the same time. And then I'm happy to know that because they at the moment, they need the ADT. I can't do anything about that really, apart from exercise physiology and the things that are really important for people starting ADT. But I can easily manipulate their novel hormone agent.
You mentioned earlier that there are probably a group of patients still, despite the enthusiasm for doublets with a NHA, who will benefit from adding in chemo. And darolutamide, the drug that's been reimbursed here recently, of course, its pivotal trial was a trial that included docetaxel. And it was docetaxel ADT plus or minus darolutamide, and a clear benefit from adding the darolutamide. And there seems to be a consensus emerging that, certainly those bad actors, as you said. So what's your practice for that younger patient coming in with liver mets or high volume bone mets, very high PSA? Do you start already yourself the ADT and the darolutamide with a view to referring on? You don't give chemo yourself, right? No, exactly.
I don't.
But we need to get the patient started. That's the point.
Absolutely, I do. And that's why I think we should be writing the first script at the very least. So even if you are not a urologist who's going to embrace this, you have an opportunity to write the first script. And I don't know what your referral pathways are like, and you chat to urologists that work in rural environments, and they don't even have to be that rural. They say it's really tough to get in and see a medical oncologist, and maybe there might be a delay of a few months, and you think, well, you've got to get that in there. It's really effective. And one of the things about docetaxel is that the problem with Chartered, and we'll forever curse Chris Sweeney, is what did that make of the TAX 327 trial? What does docetaxel do now in castration-resistant prostate cancer, where the disease is quite different, and the mechanism of action of docetaxel is very different to the novel hormone agents. So you can whack them all up front with triplet, but by not giving the docetaxel, you've brought TAX 327 back onto the table, I think, as a genuinely effective treatment down the track, because it is probably slightly better tolerated than cabazitaxel, and it's a whole of a lot cheaper. So if you're worried about costs, that's one thing that makes it easy. But with the prescription of the novel hormone agents, I'm unfortunately ruining the health budget.
Tax
for a good reason.
haven't heard that mentioned in years and years. But for the youngsters listening out there, yeah, landmark trial that showed chemo in mCRPC improved OS, and that's where we thought chemo sat until all these years later. And it did feel like that. It does feel like that's where chemo, it kind of has come forward and made a brief appearance in metastatic hormone-sensitive prostate cancer before it's going to get pushed back again. Except clearly, as the ARSENS trial showed, there are patients who benefit from the triplet. So, Renu, I know you do a lot of teaching for the young medical students. So what are your messages to the trainees out there? Because some of them will say, I'm only listening because I want to hear about this machine that is going to help with the stuck stone later on in the podcast. I have no interest in this drug-drug interaction, and I don't really understand the latest trials. It's hard to keep up with the data is the thing we often hear from trainees, but you constantly speak to trainees to say metastatic prostate cancer is really interesting. It's what we interesting, all grew up on, and we can do so well for our patients. So I think number one, take an interest, and absolutely. If it's very easy to actually acquire the knowledge to be able to speak to patients about, to assess patients, to select drugs and monitor drugs. Yeah. Or even if you don't want to do that, at least be aware of the patients who will benefit from one of these combination approaches. But how do you? And
I think you're right. I think it's identification, and I think it's the culture you set at each hospital that you work at. I remember when we were training, it was all about Zolocos. That was the treatment. You write one script and they get both, and that's what you start them on, and that's what they continue on. And since then, so many drugs have come onto the market, and I think you really have to teach by example here, and kind of do it and see how it's done for them to be able to realise, well, this is that patient that is ideal for this treatment, and this is what I need to look out for.
Can I pick up on one thing there? You know how you're saying how tough it is to keep up with the latest medical literature. Could you imagine what it would have been like being on the EAU prostate cancer guidelines between 1950 and 2000, right? You had you started ADT. That was the guidelines. You could have had one meeting in 50 years to do the guidelines. Now the guidelines committees must have to meet every 3 months to keep up with what's going on. It's mayhem.
Yeah. But I think, and Joseph, you've always been a big proponent of this, and Fred Sard in our last episode, he has, these kind of pearls of wisdom, he says, don't dabble. Yeah. If you don't have a genuine interest in this, it would be great if they can write that first script, but if you don't have a genuine interest in this, that's fine, but identify the patients and refer them early. That's key. Don't dabble. And he also says, give your best drugs early. Because people always think, let's save something for when they get the mCRPC, when they get really bad end-stage disease. But actually, no, there's survival benefit for giving your best drugs up front.
As a side note, just on that point of not dabbling, don't do something you're passionate about. It's really important that urologists go, I'm never going to do it. But you need to be involved. It's sort of like the IO agents in metastatic renal and bladder cancer. You need to be aware of the side effects, even if you aren't, because these patients are still coming to see you. So everybody needs to know this.
Yeah.
Totally right. And before we move on and finally talk about the other little teaser that we've been doing, just a brief word on imaging of metastatic prostate cancer. So here in Australia, it's been standard of care just to use PSMA PET CT, whether it's for the newly diagnosed patient or for the recurrent patient and so on. Do you do any conventional imaging, or when you've got your new metastatic patient, you've got a PET scan in front of you? Do you try and translate what would this look like in ARSENS, in Titan, in Enzymet? Do you try and?
I do a lot of conventional imaging because they're on clinical trials. Yeah. You have to do it, and that's the only reason I do it. Otherwise, they're all getting PSMA PETs. I think, the thing as a urologist, you should always be following the regulatory guideline or the regulatory approvals. I don't advocate being outside, but sometimes you've got to use some common sense. And yes, while a lot of these are, say for non-metastatic CRPC, it was on conventional imaging, but they've only had a PSMA PET, and if something's lit, is lit up, you start saying, well, could it be non-metastatic? Because back then there were different drugs indicated that space compared to metastatic CRPC. So do I want to give them chemo? Then it's metastatic. If they're not, it was less than 10 millimeters, so probably wouldn't have been seen on conventional imaging. And that was where you had to use a little bit of common sense on how to do it. But I think now it doesn't matter. These drugs are effective. If you pick up metastatic disease, I think people will benefit. And in fact, there is a trial being done with Darolutamide looking at PSMA positive, conventional imaging negative patients, and we're doing that at our hospital, which is being led by our medical oncologist. I think it'll be a good trial to hopefully show what we believe should be real and true.
Yeah, I mean, I think it's going to be key to have these prospective trials that embed PSMA PET. I mean, the other question before we move on to the little teaser is, oh my gosh, mental blank. ADT, the use of ADT in conjunction with these novel agents.
You mean not use the ADT?
Yeah, I mean, it's because we all believe that ADT is what causes a lot of the toxicity. I mean, flashback to Tim Baker, right?
And it's really topical this couple of weeks because in the EMBARC study, which is biochemical recurrence, it's not metastatic, but it's showing that whether you used, monotherapy AR pathway inhibitor versus ADT plus, the benefit was still there for the oncological side. But I suppose that's a bit off piste for today. We'll have to come back to it. Shall we go into the teaser bit? I don't do any stone surgery, but you do a bit of stone surgery, so.
Yeah, Joseph, I still recall those nights when you've got a stent to do in theatre and it's 2 a.m. and you're still waiting for the general surgeon to finish up with his lap chole and you're still waiting and it's now 3 a.m. and no sign of your patient for the stent. Is there a solution?
Well, I'm glad you asked, Bruno. No, we have. I made the mistake one day of sort of basically sitting there in the dark waiting for my damn slot in the emergency room in the emergency operating list thinking there's got to be a better way. So I sort of sketched out this idea for a stent inserter such that it could be done in the emergency room. Wow. And now 2 years later, we are well on our way to doing it. So essentially, they come in with renal colic. If you think they need stenting, you can, like putting in a urethral catheter under local anaesthetic, maybe with a bit of sedation, pop a stent in.
Wow.
There will be people listening to this podcast in a theatre holding bay at 2 a.m. Where is this thing? I could have put it in the emergency department, 6 hours ago. So
well, I would like to think that it's a really simple process. Can I tell you, medical devices will sap your soul, inventing the regulatory requirements, quality management systems, clinical research organisations, IP protection. It'll drive you nuts. It's a lot of fun, but it is so much hard work. I look around now at every single medical device and think, there's some poor man or woman who this ruined their life.
So what is the name of the device and
So it's called the Jiffy Stent.
Right.
Because my co-founder, my co-inventor is an 83-year-old legend of the mechanical engineering world in Australia. His name is Don Fry. And he told me at the end of a consult once that he could do it. And I'm thinking, who is this crazy old man? And he has done an extraordinary job. Absolutely. So we've got this fantastic thing. And so my initials were J.I., he was Fry. Jiffrey just didn't sound very good.
I thought it was just in a jiffy.
Well, that's what, it happened to double up. So that's where it came from. So
well, there
fantastic.
you go. Watch out for the Jiffy Stent coming soon in a clinical trial to a hospital near you, we hope. But
great innovation.
And only somebody with his energy could actually drive that, because it's very challenging, isn't it? It's challenging to invent something and take it through, but in the medical device industry and people, obviously the safeguards are challenging. So good luck on the
You must give us an update when it's ready to go.
Very happy to.
Yeah.
Great. What a great podcast. I enjoyed that.
Great.
I learned a lot.
I did too.
More inspired than ever to do better for our patients who were starting on ADT in every way. But as I say, sitting here at the end of 2023, Renew, it's so different to what it was even a year ago, 5 years ago. The outlook for patients is so much better. So we
the
all
landscape
need
has changed just so quickly and for the better. So, we're in a good position.
Exactly. And having access to these AR pathway inhibitors, or NHAs, or whatever we might like to call them, we will do a Twitter poll, is great for our patients. So great.
And thank you, Joseph.
Yeah.
Thank you very much for having me. It's an
fellow
absolute pleasure to be
podcaster
here.
and innovator.
Exactly. Look it up. Talking Urology. Thanks very much to Joseph for joining us. Thank you very much to you all for listening and watching. Do get in touch. Do subscribe. Do rate and review us. It helps people find the podcast and makes a bit of a difference. And we'll be back to talk to you again very soon. Goodbye from us.
Goodbye.